you very much for giving this an opportunity. I'm Byapak Podel from Nepal. Today, today I'm going to talk on this disc pen generator and percutaneous endoscopic managements. You know that there are different endoscopic spinal technique from the endoscopic assisted to the uniportal to the biportal, depending upon the instrument we use and the portals we use. And to be a true endoscopic spine surgery should be done percutaneously with stab incision with foot endoscopic system, utilizing the soft tissue dilation rather than cutting technique, and should be done under constant saline irrigation. So the tubular endoscopic system is the true endoscopic surgery. And recently, EO spine consensus paper has been published on the nomenclature of the endoscopic procedures. It has defined the full endoscopic decompression and endoscopic assisted. It has put the uniportal discectomy and the stenotic decompression as a full endoscopic decompression, whereas this Destandu technique and UVE technique are put in endoscopic assisted surgery. And there are certain advantages of endoscopic spine surgery because as we master, we can operate the patient in the shortest period of time, and there will be a less blood loss, and there will be less pain, and the rehabilitation will be faster, and hospital stay will be shorter, and the patient can return to work early. And pain generators can arise from any part of the spine, from the anterior column to the middle column to the posterior column. In anterior column, it is from the discal pressure change. In the middle column, it is due to the change in the neural and chemical structures. And from the posterior column is from the deep somatic derangement. But my today topic is mainly the discs, the pain generator. So I will mainly focus on the middle column. So disc is the important structure. When it is pathological, it can be associated with low back pain with or without radiating pain, discogenic back pain, and pain due to the prolapsed discs and pain due to stenosis are commonly encountered in our daily practice. As you all know that the disc has two layers, annulus outside annular fibrosis and inner nucleus pulposus. Annulus fibrosus has also two layers, and nucleus pulposus is a highly hydrated aggregate containing gel, and this disc lies between the two end plates. So what is important, I will come about this anatomy. And there is a constant homeostasis of the disc physiology with a balance of the mastocytic production and of the stimulator and inhibitor and the breakdown of the matrix. And the disc, as we know that disc is innervated posteriorly by the sinovertebral nerve, and through the gray ramus communicans, it has connection with the sympathetic trunk, and it is the connecting, the sinovertebral nerve is connected to the sympathetic nerve, and both the ventral rami and the dorsal rami work together with the synovial nerve to assist in the segmental function, because segmental function is very, very important. With this function, there will be a problem with the start. And we all know that these end plates are innervated by the basivertebral nerve. These are the pain generators. And this is the picture that shows that discs and end plates are highly densely innervated for the segmental dysfunction, because these are the pain. That's why somewhere we have to do discectomy, somewhere we have to do the fusion surgery, depending upon the pathology, what it has done. And when this symptomatic discs from the degeneration has been studied, it has been found that there is a growth of the vascular tissue inside the nucleus pulposus. Actually, nucleus pulposus in a native form, asymptomatic form, is avascular or neural. But when it gets symptomatic, there is a growth of vascular cavernous tissue inside the nucleus pulposus. Not only the vessels, there is found that the growth of neural tissues inside the nucleus pulposus, that is the pain generators in the spine. And extensively, there are the pain markers has been found in the symptomatic disc than in the control discs. And there are some massive expression of the growth factor like basic fibroblast growth factor beta, transferrin growth factor beta 1, and connective tissue growth factor in the symptomatic degenerative discs. Whereas in all symptomatic degenerative discs, there is no nerve growth, no formation of vascular granulation, and the expression of only a few growth factors. So we have to differentiate between the symptomatic and asymptomatic degeneration, because we are operating upon the patient, not on the MRI. MRI may show the degeneration. Well, if there is no symptoms or symptomatic, we should not tackle that one. We have to really find out whether it is pain generating or not. And how the pain is produced in the discogenic back pain. Initially, there will be internal disc derangement that leads to the internal disc tear, and that leads to the ingrowth of the vessel that I talk about, the stimulation of the sinovertebral and the basivertebral nerve, and there will be the activation of the pain substances so that you will have a back pain. That is the cause of the discogenic back pain. What about the lumbar disc herniation? The first initial insult is the same, the internal disc derangement that leads to the internal disc tear, and that leads to the herniation, and there will again the growth of the nerve and vessels with the stimulation of sinovertebral and basivertebral nerve, and there will be activation of the pain substances. On top of that, there is a mechanical pressure over the root or the cord, or depending upon the pathology, it gives rise to the back pain and also the radiating pain, and sometimes the neuropathic pain when it is the central type of disc herniation. We don't find the radiating type of pain inside. And what about the stenotic pain? How it is pain is generated in stenosis? The same initial internal disc derangement that leads to the internal disc tear, that leads to the segmental dysfunction, that all column that I described, either in anterior, middle, or the posterior. In the posterior part, we have medial branch of the sinovertebral nerve, and this is a fasciopathy. So because of dysfunction, there is a spinal stenosis because of the hypertrophy of the bone around it, the spinal canal, and the hypertrophy of the ligamentum flavum. So because of that, there is the ingrowth of nerve and vessels with the stimulation of sinovertebral, basivertebral nerve. There is activation of pain substances, and there is a mechanical pressure over the root and cord. So again, we'll have a low back pain, claudication, and with or without radiation, depending upon the pathology where the location is. So how the discogenic back pain is managed? There are two types of the discogenic back pain. One is arises from the annular disruption, that we call annular disruption induced low back pain. Other is derived from end plate disruption. Because end plate are innervated by basivertebral nerve, annular end plate disruption is associated with the sinovertebral nerve. So how we tackle this? It can be done by the laser ablation. So the landmark paper on this is published now, and we call this transforaminal laser ablation of the sinovertebral nerve. If we ablate the sinovertebral nerve, we'll call Tesla. And if you ablate the basivertebral, we call Tebla. This is the promising percutaneous endoscoping technique so far. And prior treatment like I did, thermal procedures, for discogenic back pain has less favorable outcome and has problem. However, this technique, which we have published together with my mentor Henson Kim, it has shown that it has 96% good to excellent result for Tesla, and it's about 93% for the basivertebral nerve ablation. How we manage the PIVD? Now it can also be managed as percutaneous full endoscopic technique. Initially, the disc herniation with the cauda equina syndrome, disc herniation with spinal stenosis, recurrent disc herniation is disc herniation with stable spondylolisthesis, or the calcified discs are once considered contraindicated, but now is no more contraindicated of endoscopic surgery. We can do all type disc herniation with the endoscopic technique with a 96% success rate according to the McNubb criteria, and 98% success for endoscopic success grading. This is the endoscopic success rate we have described, and the difficulty for the surgeon and the grade and the score of the doing the endoscopic discectomy depending upon the nature of the disc. We can go through the literature, you can find in the detail now. And endoscopic surgery, the discectomy can be done through the transforaminal approach, interlaminar, or transperineal, and other approaches. And there is a difference between inside and outside. Dr. Hu has also explained about this. There is a difference because in and out approach, we go directly into the disc, but out and in approach, we remain outside the disc and we target the pathology only. So the difference is in and out approach, there will be a big range. So the recurrence after the discectomy will be high in and out approach than in the out and in approach. And there is a now shift in the transforaminal endoscopy discectomy from the inside out to the outside in approach. And this transforaminal endoscopy has 3 routes. We can do through the 3 routes depending upon the location of the disc. Exiting root approach, interverted root approach, suprapedicular approach. So the for bilateral, foraminal, and superior migrate discs, we use the exiting root approach. And interpreted root approach is the paracentral and central discs, mild inferior migrated discs, high canal compromised disc herniation, and for high grade inferior migrated discs, we have suprapedicular approach. And likewise, in interlaminar discectomy, we had two approaches, shoulder approaches and axillary approach, depending on the location of the disc where it is located. So there are the problems with the discectomy, like high iliac crest, narrow foramen, migration, recurrence are the problems. But there is a solution for this problem too right now, because we can approach the high iliac crest by the transiliac approach or by the interlaminar approach. We can do this problem of the narrow foramen can be solved with the foraminoplasty either by the reamer, bore, or sealer by dissection of superior facet, superior vertebral knot approach, or S-cut as suprapedicular circumferential opening technique. Because this S-cut technique is usually used for discectomy high-grade inferior migrated lumbar disc herniation. And migration is also a problem, which is migrated discs wasn't unable to treatment in the past, but is now enabled to treatment because we have C-cut technique, suprapedicular techniques, transpedicular technique, interlaminar technique with the use of semi-rigid flexible curve, probe, foraminoplastic, ventrally approach, down level interlaminar approach, and contralateral foraminal approach. So depending with the instrument and approaches and techniques, we can manage this migrated discs as well. So there are a lot of literature that supports that. That I've already said S-cut is used for high-grade inferior migrated. It's recently published. And recurrence is also a big problem. The solution is found that for annular sealing, in interlaminar approach, annular sealing is one of the method, and in the transforaminal approach, targeted discectomy, that means outside in technique, is one of the solution for that. And through the interlaminar approach, rather than resecting the ligamentum flavum, if you do with the ligamentum flavum splitting, it is an advantage for the recurrence, because there, when the study is done, there is a found that there is a without the sealing, this annular sealing, the recurrence rate is 13.5%, with sealing is 5.5, and when it is augmented with ligamentum flavum splitting, it is found that recurrence had decreased from 5.5 to 2.5%. So these are the solutions. So how we manage the spinal stenosis? This can also now be managed with percutaneous endoscopy technique. We call this percutaneous endoscopy sternocleidomastoid lumbar decompression, PESLD, but recent consensus has changed the name that we call now that ULBD, LEUVLD. And
you are in your last minute, please, sir. Hurry up.
Okay, sir. The result is 90% good. Okay, sir. And this now been extended indication are there for fusion, discitis, Bartholdi syndrome, spinal tumor graded population, obese population, and it can be used for the fusion, which is evolving technique by transcamin approach or endothelip and interlaminar approaches. There are a lot of literature evidences for that. So it's a review, systematic review. It has shown that there is a good surgical option for degenerate disc disease instability, spondylolisthesis. So a lot of evidence is also available for the infection also. So recently this meta-analysis has cleared that it has the intervention in spinal infection is encouraging, and there is a high rate of causative pathogen identification, and it provides satisfactory clinical outcome. But it shows that large number of control trial is necessary. So we can also use in the Bartholdi syndrome. As we know that Bartholdi is the enlargement of the hypertrophy of the alpha transfer process, and sometimes we have pseudoarticulation with the pelvic thing. So there is a compression of we can decompress with endoscopic technique, and UB is the emerging technique where you use the by two portals, and there is remote future indication for the endoscopic surgery is to use for the disc regeneration as a visualization and delivery tool of biological materials. So if the more of the information can be achieved, can be achieved from this book, Endoscopic Procedure in Spine. We also have one chapter here. So the my presentation, I'm finishing now. The treatment of discogenic back pain, discectomy, and stenosis, decompression, is fusion will all be percutaneous in the future. In due course of time, all spinal problem can be solved by percutaneous endoscopic technique. So I would like to acknowledge my professor, mentor, Professor Hyun Kim, for mentoring me and the spinal endoscopy. And I would like to welcome you to the Nepal, this mystic place with the mountains and Himalayas. All tallest mountain, highest mountain is in Nepal, and we have God and Goddess, and very natural resources.
Thank you so much.